so we're responding to a 24-year-old male who has had a syncope event at home. We've gone through his ABCs, trauma sweep and a set of vitals, and they're all within the normal range and there's no abnormalities to be seen. So we've now got the patient sitting upright here, and we're going to go through some differential diagnoses and just the general assessment of a syncope to demonstrate the skill. So Sam, what were you doing when you had this fainting event?
I was running on a treadmill and sort of felt that I was going to faint and I went to sit down. And,
Then you fainted?
Yeah.
Yeah? How long were you on the treadmill for?
About 45 minutes.
45 minutes? Is that a normal time amount for you?
No, because I'm trying to train for a marathon, so I've been trying to increase how much exercise I'm doing.
Okay. And have you ever had a syncope before? Have you ever fainted before at all?
Yeah, once about 3 years ago when I was running for a marathon.
Okay.
Yeah.
Alright. Do you have any past medical history? Have you had any cardiac problems in the past?
No.
No? Has your family at all?
No.
No? Have you got any allergies?
No.
No? Are you taking any medications at the moment?
No.
No? Okay. I'm just going to chuck on a 12 lead. So for the purpose of this video, I won't actually demonstrate the skill, but I put on a 12 lead. The 12 lead shows no abnormalities at all. So we're just looking for any arrhythmias or abnormalities in his QRS complex that would show some cardiac output problems or anything like that. Also looking for within the neural syncope if there's any bradycardia or hypotension, which he has none of, or if he is hypoxic at all, which could be the case with his exertion at the moment. So we're just going to go through some differentials of your loss of consciousness. So have you had any alcohol today at all?
No.
No? Have you had a seizure? So Jess, did you see him jolting around at all when he passed out?
No.
No? And just looking at your tongue quickly, so looking for any bite marks or any blood, can't see anything there, so if there's no, a seizure is not indicated really. You don't suffer from epilepsy at all?
No.
No? So your BGL was normal of 7.3, so that would suggest that you don't need insulin, you don't have diabetes at all?
No.
No? So we can rule out hypo or hypoglycemia. Overdose or underdose, you're not on any medications and you haven't taken anything today?
No.
No? And then we did a trauma sweep earlier that showed no trauma, you didn't fall at all, did
No.
you? No? So our mechanism wouldn't suggest that either. Infection, have you been sick in the past
No.
24 to 48 hours? Been well? That's good. And you don't have any medical history, so we're going to rule out psychosis and sepsis too. Now, going through the vasovagal route of a syncope, how was your posture when you felt faint? You were running, you were saying?
Yeah.
So running for 60 minutes, that like a long period of standing can provoke a syncope event. Also provoking factors, are you stressed at the moment?
Yeah, but stress with exams as well, yeah.
Okay, fair enough. And also the long exertion time period would be another provoking factor. And you're a bit sweaty at the moment, I can see. Are you normally this sweaty after a run?
Yeah, I'd say it's quite normal.
Yeah. Okay, and Jess, what was Sam's colour when he had a faint?
I think he was quite pale, eh?
Okay, so that is normal for a syncope. And yeah, so then we'll just go on to just ruling out a TBI as well. Your vision is okay at the moment?
Yeah.
Yeah, no blurriness at
No.
all? Okay, I'm just going to get a pupil torch. And we'll just quickly look at your reactivity and yeah, all that. So that's fine as well. So we're going to just rule out a TBI. You're not feeling confused at the moment?
No, I don't think so, no.
No? Was he confused at all just when he first had the syncope event?
Yeah, a little bit.
Yeah? For how long?
For about a minute.
Okay. Yeah. Alright. You haven't just gone for number ones or number twos in the toilet?
No.
No? Okay, cool. Were you coughing or vomiting just before you
No.
passed out? No? And when was the last time you've eaten?
About 2 hours ago.
2 hours ago? Okay, cool. Now I'm just going to quickly check your your blood pressure. We're looking for postural hypertension, which may indicate an underlying cause of illness for the syncope.
Mm-hmm.
So I'll just put this on. So we're going to do this sitting down and standing up. Okay, so that came back as same as before, 115 over 85, so that's normal. And then I'm just going to get you to stand up for me too, please. And we'll do it again. So we're just looking for a systolic fall of 20 or higher, or a diastolic of fall of 10 or higher. So I'll just do this one more time. You're not feeling dizzy at all now?
No.
Cool. Okay, so that's about the same as well, so we can rule out the postural hypertension. So just going off that general assessment, we have found the red flag of syncope on exertion, but I'm just going to use my pocket CPGs just to quickly make sure I haven't forgotten anything. So any abnormal vital signs. No, those are all within the normal range. Would you say you're back to normal now, Sam?
Yeah, I think normal.
Relatively normal. Okay, so we can rule out that red flag. Your ECG came back normal. You haven't got any shortness of breath. Your rest rate was 16, which is good. You haven't got any injuries. It did occur during exertion, so that is a red flag. You're not pregnant. You don't have a headache at the moment, and you have no congenital or valvular heart disease. So we can rule that out as well. So just because you have one red flag present today, I'm going to have to take you through the hospital just to have a thorough check of see if there's anything underlying happening, and just to make sure that you'll be okay. Just for future references, I'd say maybe slow down on the exercise a bit, not go for so long, and then just slowly see how you go, because we don't want you to have another syncope if this is the trend that's coming at the moment, falling into at the moment. So yeah, we'll take you through the hospital.
Can you tell me what's wrong today?
I just had this pain. I think it's my migraine.
Can you tell me where the pain is at the moment?
The right side of my head.
And have you has this happened before?
Yeah, I had a migraine like 3 months ago.
And is the location of the pain today, is it the same as where it was before?
Yeah, it's the same side as well.
Okay. And can you tell me when the pain started?
It's like an hour ago.
And did it come on slowly or rapidly?
Slowly.
Track the pain for me.
It's like this throbbing pain. It's
On a scale of 0 to 10, 10 being the worst pain you've ever felt, 0 being no pain at all, can you give this pain a number?
I'd say about an 8.
1 and 8? Okay. And are you experiencing any nausea or vomiting with your headache?
Nah,
Are you experiencing any neck stiffness?
I don't think so.
Oh, okay. Is there a palpate of your neck against your face? Okay. So I'm checking to see whether there's any pain or neck stiffness, because that can be a sign of meningitis of a headache. And also, I'm trying to rule out whether sinusitis or temporal iritis is present. So there wasn't any pain where I was palpating?
No.
Okay, that's good. And are you experiencing a fever?
No.
Are you experiencing any hearing loss?
No.
Okay. Any ringing in your ears?
No.
Any visual disturbances?
No.
But do you feel dizzy or that the room is spinning?
No, I just had sort of these like spotting when the migraine first started.
Okay. And have you got rashes anywhere?
No.
Is there a look at your arms? Okay. So I'm looking out for any non-blanching purpura or petechiae, which can be a sign of meningococcal septicemia. Any other symptoms that you're experiencing?
No.
Is there anything that makes your migraine worse?
Loud noises and bright lights.
Okay. Is there anything that makes it better?
Like these painkillers that the GP gave me last time worked pretty well.
Okay. And what were you doing before the pain started?
I was trying to study,
Okay. Did you have any recent accidents or trauma before the headache started?
No.
Okay. So now we're doing a neurological assessment. And is it alright if I shine a light in your eyes to have a look at your pupils? Okay. So I'm checking to see whether pupils are equal and reactive to light and accommodating, which they are. So that's good. Can I get you to follow my finger? Just keep your head still, okay? Okay, that's good. Okay. That's good. Okay. And can I get you to clench your jaw for me? Can I get you to give me a big smile? Puff out your cheeks. Okay. Can you say I and open? Good. That's good. Can I get you to raise your eyebrows? Okay. Stick your tongue out and move it left to right. Okay. And can I get you to shrug your shoulders for me? Look left and look right. Okay. Cranial nerve 8 is intact because the patient's following my commands. Can I get you to squeeze my hands for me? Good. Okay. Can I get you to raise your arms up with palms facing forwards and close your eyes? Okay. There's no pronator drift, so that's good. So, there's no neurological deficits. Cranial nerves are intact. Fast test is negative. And so, have you got any allergies, Jess?
No, not that old.
Okay. Are you on any regular medications?
No, but I took some ibuprofen just 2 minutes ago.
Okay. And how much? Do you know the dose of your ibuprofen?
400 milligrams, I think.
Okay. So it's 2 tablets. That's good. And are you taking any anticoagulants such as warfarin?
No.
Okay. And do you have any medical problems apart from migraines?
No.
Is there a chance that you might be pregnant?
No.
Have you got a history of an intracranial bleed?
No.
Have you got a family history of stroke or cerebrovascular abnormalities?
No.
Have you been well recently?
Yeah.
Okay. Have you lost consciousness at any point during the headache? No. Okay. So looking at her vital signs and from an assessment, I believe that you're having a recurrent episode of your migraine. So at this stage, I'd like to give you some pain relief. So because you've already had ibuprofen, I'm going to withhold that and I'll be giving paracetamol. So I've got paracetamol, which is an oral analgesia. It's going to help relieve some of that pain you're feeling from your migraine. So can you tell me your weight, please?
65.
65, okay. So I'm going to let my off-sided drug check that this is paracetamol, okay? And so some side effects of paracetamol is nausea and vomiting. It takes about 30 to 60 minutes to work, okay? So at 65 kilos, I'll be giving 2 tablets or 1 gram of paracetamol, okay? So I'm going to be documenting the time that it was given it. I'll be withholding opiates as well for the pain, and I'll be giving normal salines instead because it's been proven to be more effective in treating migraine because it directly prevents the overstimulation of cells, and it is also outlined in the clinical practice guidelines for the treatment of migraine. So this will be given intravenously at up to a maximum of 1 liter. How you've presented your migraine, does it feel different from other episodes of your migraine?
No.
At this stage, Jess doesn't need transport to hospital, and her symptoms can be managed in the house. So I'm just going to make sure that there are no red flags present, and I'm going to be referring to my checklist. You don't have any headache or neck pain following neck manipulation. You don't have any neck pain or neck stiffness. This onset of headache wasn't sudden. Her temperature was less than 37.5. She doesn't have persistent vomiting. There's no focal neurological signs, and she didn't have an altered level of consciousness or a history of altered level of consciousness with the onset of her headache. She didn't have any trauma before the headache started. She's not taking any anticoagulants or has a non-bleeding disorder. She has no signs of temporal arteritis. She's not hypertensive or is pregnant and doesn't have a history of intracranial bleeding. She doesn't have a family history of cerebral vascular abnormalities, and the onset of her headache was not during sexual activity. Before I leave her at home, I just have to explain, I'll be giving her some health promotional tips that can help with her migraine. So some things that can help is to rest in a calm, quiet, dark room. So this is to reduce as much stimuli as possible, which can worsen your migraine. Another thing you can do is also avoid triggers, such as things that that bring on your migraine. You can try and keep yourself as safe as possible when you have these episodes. For example, if you're driving to pull to the side, because she's got no red flags, she can be safely left at home. So just if your symptoms don't improve, you can see your GP, and with your medication, you can continue taking your ibuprofen and paracetamol on regular time intervals, and I'll tell you more about that later. As I'm not transporting Jess to hospital, I'll be referring to my non-transport checklist to ensure that Jess is left at home safely. So the patient has been fully assessed, including a set of vitals and appropriate investigations. She's got none of her vital signs were abnormal. She's got no serious injury or illnesses, and if any potential ones have been excluded. She had no red flags present in the headache section. Okay, Jess, could you just walk to the door and back for me? I'm just checking to see whether she mobilizes well.
Yeah.
She's been given information on when to seek help as well, and a PRF would be left with the patient and how to exit.
So today we've been dispatched to a 40-year-old female with severe lower back pain. So back pain usually comes in three common types of symptoms. This includes non-specific symptoms like musculoskeletal, sciatica, which is pain radiating down one leg, and symptoms of both, which could indicate something more serious. So when I go in there, I'm going to be watching out for signs of malignancy, trauma, infection, inflammatory arthritis, and also back pain mimics, which could be AAA, GI disease, kidney stones, and pelvic inflammatory disease. So Sophia, why have you called us today?
I usually have back pain, but today I woke up and it was way worse.
Okay. So while I'm not going to ask you a few questions, Jess, can I get you to take some vitals?
Yeah.
Is that right with you?
Yeah.
Cool. So what were you doing when the pain came on?
I just woke up and I just had this pain and I couldn't get out of bed.
Okay. Does anything aggravate it or make it worse?
Sitting, standing, I can't even get out of bed. It just hurts when I move.
Does it just feel better when you're lying down like that?
Yeah.
Alright. And how would you describe the pain?
Sharp and like searing, and it's like
Okay.
all on my lower back.
Lower back, does it radiate anywhere?
Yeah, like down to my bum and like down my leg as well.
Okay. Which leg is that? Is that your right leg?
Yeah.
Okay. So it goes down from your lower back, through your bottom, down your leg, and into your foot? Would you
Yeah,
say?
yeah, like it's
Okay.
like
And out of 10, how painful would you say it is?
an 8.
Okay. Do you have any other medical history?
No.
Any signs of recent trauma?
No.
And have you been well recently? Normal bowel motions, normal bladder and everything?
No.
Okay, that's cool. So there were no abnormal vitals, apart from her heart rate, which was a bit high, but I'm just suspecting that's due to the pain at the moment. So Sophia, do you mind if I expose your back? So just exposing her back, I'm looking for any signs of bruising or swelling, which I can't see. I'm also looking for signs of kyphosis or lack of lumbar lordosis, which can contribute to lower back pain. Sophia, do you mind if I palpate your back?
Yeah.
Can I? That's okay? Okay. So I'm just going to palpate her kidney area. Is there any tenderness there?
No.
In palpating her ribs? Any tenderness?
No.
So I can rule that out. I'm also going to palpate down her spine, and then either side of her spine along paraspinal muscles, just to rule out and differentiate between a paraspinal cause versus a spinal cause. Sophia, do you mind, or was there any tenderness or pain down your spine? Okay. Do you think you could turn over for me just so I can have a look at your abdomen? So do you mind if I expose your abdomen? Cool. So again, I'm just looking for any signs of bruising or swelling. Do you mind if I palpate? Alright, let me know if there's any tenderness or anything like that. No tenderness? Right, so if Sophia had any tenderness or abdominal pain that was radiating down to her lumbar, back, or flanks, I would suspect any conditions such as pancreatitis, cholecystitis, peptic ulcer, or a leaking AAA. Sophia, do you think you could reach forward and touch your toes?
No.
You can't do it? Right, do you mind if I take off your shoes, just so I can look at your face lines? So now I'm just going to lift up your affected side and just tell me if that hurts you. Yeah, so I'm just going to bring it to about a 30 to 60 degree angle. Are you able to pull your foot forward? Okay, so she can't do that very well. I'll put that back down and just compare to her other leg. Does that hurt at all? Can you pull your foot forward? Alright, that's good. Put that back down. And just looking at her limb base signs, her colour looks equal on both sides. Just feeling for a pedal pulse. You feel that on both sides. Can you wriggle your toes? So not as well on her affected side. If I pull in towards Sophia, could you pull them back towards you? Yeah,
so it is very weak on her right side, which suggests that there's L5 involvement. And if I push my hands on the back of your feet, can you push? Again, it is weak on her right side, which suggests S1 involvement. So we've already established that Sophia has one of the red flags present for lower back pain, which is that she's unable to walk. So Sophia, we definitely will be taking you to the hospital, if that's okay, just to get you checked out. What's your pain? Is it still 8 out of 10?
Yeah.
Still 8. Okay, so would you like some pain relief?
Yes, please.
Yeah. Have you had morphine before?
Yes, I have.
You have? Cool, so you're not allergic to it or anything?
No, I don't have any allergies.
That's good. So I've got an IV in, and that means we can go intravenously, which means that it'll be able to affect you a lot quicker and take the pain away a lot better. But it may make you feel a little bit dizzy, maybe a little bit nauseous, but it will help a lot. Is that alright?
Yeah.
Cool. Jess, can I get you to start drawing up the morphine?
Yeah.
Make sure you do a drug check when you're, yeah?
So, morphine, 1 meg and 1 mil, expires next year.
Yeah. Morphine, 1 mg/ml, expires next year. Cool. Cool, thank you. So I'm just going to go through the red flags just to make sure that I haven't missed anything else. So, Sophia, do you have any loss of bladder or bowel control?
No.
No. And do you have any rigours?
No.
No. And due to the vitals before, she didn't have a temp that was greater than 38 degrees, which is good. If she did, I would suspect that she might have an epidural abscess.
Sharp up.
Cool. She doesn't have any other abnormal vital signs. Do you have any pain in your thoracic spine or chest? No?
So,
Okay, cool. And on assessment before, we found that she didn't have any abdo pain. I know you've got pain, but do you think that you have altered sensation, like, like pins and needles or tingling or anything in your saddle area, which is your lower back and bum and kind of upper thighs?
yeah, it feels a little bit numb.
It feels numb. So this is a red flag. This is because it can cause cauda equina syndrome, which is compression of the bundle of nerves below the ribcage. This can go down to her lower legs or her abdominal organs, and not only cause altered sensation, but also loss of bladder and bowel control, so it can be very serious. Would you agree with me that you've got pain and altered sensation in one of your legs, but not both?
Yeah, in my right one.
Cool. And she is unable to walk, which is another red flag. And have you been well recently?
Yeah.
No sickness or anything?
No.
Alright, cool. So I'm just going to double check that I've got all the red flags. Yeah. So because she has all those red flags present, we're definitely going to be taking her to the hospital. Is that alright with you? Yep, so how's that morphine going?
Yeah, I've drawn it out.
Cool. So I am suspecting that you've got sciatica due to the characteristics of your presentation. You have decreased dorsiflexion and plantar flexion in your foot. And also you've got pain and decreased sensation radiating down the posterior leg. So that all suggests sciatica and suggests that you've got L5 and S1 involvement, which is like common in 95% of sciatica cases. Because sciatica is usually due to an underlying condition such as herniated disc, we need to take you to hospital just to get that checked out. Alright, so we'll give you some pain relief. Yeah, and once we've done that, we'll get you onto the stretcher. So once Jess is finished there, I'll get her to go and get the stretcher. Is that okay, Jess?
Yeah.
Yeah, and we'll pop you on the ambulance and take you up to the hospital. Is that alright with you?
Yeah.
Cool. So I'm going to administer 3 mils of morphine. We've got a blood pressure, and after 5 minutes we'll take another one because morphine can cause histamine release, which can cause vasodilation. Yeah. So that'll take about 5 minutes to work, and just let me know how you feel.
Nosebleeds can be caused by a variety of things, so mild trauma, facial trauma, coagulopathies can be caused by medication, patient's medical history, and also hypertension, even though hypertension is very rarely a direct cause for a nosebleed. So 90% of nosebleeds are anterior nosebleeds, which can be caused by mild trauma, dry mucosa, and it originates from the capillaries. So it's typically mild and can be controlled by direct pressure. The other 10% is posterior nosebleeds. It normally originates from a single artery or vein. It's more common in elderlies, especially those that suffer from hypertension and are on anticoagulants. It is the more kind of serious and can be deadly sometimes. Arriving on scene, we see our patient is tilting on her head. So, Sophia, my name's Jess, we're from the ambulance service, and first of all, I just want you to lean forward instead of backwards, just because the blood can drip down from the posterior pharynx and go into the stomach, and that can sometimes cause vomiting as well. So instead of leaning, I want you to put your head up like that and just sit upright. Yeah, so I want you to apply pressure on the soft part of your nose, just like so. Yeah, so keep that pressure on. And you want to show the patient how to apply pressure as well, just to make sure that it's correct. So while we are compressing for about 15 minutes, I just want to get my offsider to take some vitals as well and draw up the adrenaline, just in case we do need it after 15 minutes of pressure. So Sam, I'm going to need you to draw up 1 mg and 1 ml of adrenaline and dilute it in 9 ml of saline. Yeah, and I'll get you to perform a drug check as well, and also attach it to a mucosal atomizing device, the nasal one. Yeah, so I'll just drug check that. So adrenaline, 1 mg and 1 ml, expiry date 2019. That is, how long have you been bleeding for, would you say?
About 10 minutes.
Okay, and where is it bleeding out of?
I think my right nostril.
Okay, so it's a unilateral bleed. And how much blood do you think you've lost?
I'd say maybe a cup and a half. That's all the tissues on the table.
Okay, I'd say that's about right. What were you doing when the bleeding started?
Nothing, I was just sitting in class and then it just started.
Okay. Do you normally get nosebleeds?
No, I've had a couple in my lifetime, mostly when I was younger, from picking my nose.
Okay, so what's your medical history? Do you suffer from any kind of like clotting disabilities, or have you had any facial surgery or kind of facial trauma?
No, I have no surgery or no trauma.
Okay. Do you have any allergies to any medication?
No, but I've had a sinus infection for the past few days.
Okay.
And I've been using like a nose spray to clear my nose.
Okay. So do you use any recreational drugs by any chance? No. It's been 15 minutes since we started the compression, and I just want to kind of have a look at the status of your bleed. So I'll just get you to gently release that. So we can still see a constant oozing through Sophia's nose on the right nostril. So since the bleeding has not stopped after 15 minutes of compression, as per CPG, we will decide to administer some intranasal adrenaline. So the adrenaline is a drug of choice due to the fact of its vasoconstricting properties. So the vasoconstriction can just promote the stopping of blood. So we have the adrenaline connected to a nasal mucosal atomizing device. So Sophia, just something that will go up your nose, excuse me, and it will just create a light spray. And after I spray it, I'm going to need you to continue compression of your nose for another 15 minutes. But before I start this, I'll just get you to lightly blow your nose just to remove the blood clots, or we can sometimes use suction to remove that as well. So I'll just get you to lightly blow your nose and remove that. So we will put it up Sophia's right nostril, and we will just administer 0.2 mg of adrenaline because Sophia is an adult. If Sophia was a child, I would call up clinical desk and seek clinical advice. So now that's administered, I get you to continue compression on your nose. We want to check the status of the bleeding, so I'll get you to release that once again and just see. Lovely. We'll gently clean the wound and just have a look. And so Sophia, I'm going to just use a purple torch and just have a quick look up there. And up there we can see there's a slight irritation on the septum, which I suspect is the source of the bleed. So it is indeed an anterior bleed due to Sophia's history and maybe the use of the antihistamine nasal spray and also the sinus infection that has caused some irritation on the septum. So because of Sophia's medical history and the fact that the bleeding has stopped completely after administration of adrenaline, there is no specific follow-up needed because Sophia's not on any kind of anticoagulants such as warfarin or dabigatran. So I will just leave Sophia at home with a PRF form that can direct Sophia what to do if there is another episode or anything like that. Rather than if Sophia was on anticoagulants, I would ask her to go to a GP within 24 hours to review her medication. If the bleeding didn't stop, however, after adrenaline, I would probably get Sophia to be seen by a doctor in a couple of hours, especially if Sophia was on anticoagulants. I would probably take her to ED to be seen. That is also taking into consideration the amount of blood Sophia has lost during this time. If the bleeding was severe or moderate, and I can see that she has lost a lot of blood, I will take Sophia to see a doctor, maybe at the ED. Even if it has stopped after the administration of adrenaline. If it does not stop, I would take Sophia to ED straight away. Because we are deciding not to transport, I would use the non-transport checklist. So check Sophia's vitals, and they are all normal, within the normal range. So there are no signs of hypovolemic shock, and her blood loss didn't indicate so either. So, but if there was and she lost a massive amount of blood, we would treat the hypovolemic shock. So the non-transport checklist, the patient has been fully assessed, includes a set of vital signs and appropriate investigations. And the next one, none of the vital signs are significantly abnormal. Serious illness or injury has been reasonably excluded. So we have considered that Sophia has a sinus infection, which has caused the bleed. So no red flags are present if the clinical condition is one that's contained within the red flag section. There's no red flag section for expistaxis. The patient is seen to mobilize. Noting that the patient is unable to mobilize, there must be a clinically minor long-standing condition preventing this. I'll get you to stand up and just walk to the door for me, please. Lovely. Yep, and sit back down so the patient can clearly mobilize. The patient and caregivers have been given an explanation or when to seek further help. So, Sophia, if this does happen again and it doesn't stop, don't hesitate to give us a call back. And we will also leave you with a PRF form that will record everything that we have done today. So, we have decided that the patient can be safely left at home.